trooper.
Yes, sir.
Were you assigned to the district attorney's office?
Yes, sir.
It would be the Plymouth County DA's office, meaning these prosecutors here, right?
Correct, sir.
Actually, you have an office in their office, right?
Correct, sir.
You don't have to call me sir. So on the first time you got involved with this case was on the evening of, was it the 24th or 23rd?
Tuesday. I think it was the 24th.
Okay. And do you recall what time it was that you went there?
To the South Shore Hospital.
Yes, I'm sorry.
Approximately 7:30 p.m.
Now, at that point, you had known, obviously, that this was a major investigation involving the death of 2 children and 1 serious injury to another child. Is that correct?
Correct.
The media was absolutely insane all over the location of the house and in the hospitals and everywhere. Isn't that right?
I recall media at the house. I'm not sure about the hospital stuff.
Okay. It was a fairly horrific and largely attended to, if you will, event. Is that correct?
Yes.
And Lindsay was, when you went to the South Shore Hospital, that's where you saw her before she was transferred to the Brigham and Women's, right?
Yes.
When you went in to see her at the South Shore Hospital, she was in the emergency room, right?
Yes.
Would you agree with me that she was pretty well, she had the intubation tube in her mouth, she had tape on her face, she had her arms all taped up and wires and tubes and everything else, right?
Yes.
And it was a very confusing and, quite frankly, shocking sight to walk into that room and see her there in that condition, right?
Yes.
And you, about your duty, collected clothing and her wedding band, correct?
Yes.
And you went through all that with the items you seized, and you introduced those into evidence and noted what the government said appears to be stains, but it was blood on her clothing. Is that right?
I would say. Yeah.
In your experience?
Yes.
Okay. Any shoes? Did she have any shoes, sneakers, slippers, anything like that?
I don't recall shoes. I think 2 black socks, but I don't recall shoes.
Right. If there were shoes on her person or brought to the hospital, the odds are that when they saved the clothing, they would have saved the shoes as well, right?
Yes.
So you took the clothing, and then you went to the Boston Children's Hospital, right?
Yes.
And after you left the Boston Children's Hospital, you went back to the house and then assisted in the search of the property with a search warrant?
Yes.
And were you the lead investigator at that point, or were you one of the guys just searching?
I was not the lead investigator.
But there was a court order, search warrant, right?
Yes.
And you, meaning collectively you, knew that you had a search warrant that authorized a search for a number of items, including medications or pills or pill bottles, right?
Yes.
I don't have to grab this and ask if you saw this. You never did see that, did you?
I did not recall seeing that, sir.
You don't know what, if anything, was inside that item, right?
I don't know.
And counsel asked you whether or not it's a collaborative effort on the part of the detective units and that you all collaborate and work together. Can you explain that? Do you report to each other? Do you keep each other advised as to what you get for evidence?
Yep. So when we go into a house, we're not familiar with the layout. We'll walk the house and figure out where bedrooms are located, and then essentially we kind of just break up into teams, if you will, and search the residence as evidence is located. And at that time, as the evidence officer, I would be alerted that, hey, there's evidence here. We're going to document and collect it.
Okay. And you videotape the scene and you take photographs of the areas, the different rooms, right?
I do not, but the crime scene does.
But you were in the house and you were able to observe the rooms. You could see all sorts of wall hangings and paintings and fingerprints and handprints and all that stuff on the wall, right?
Yes.
Downstairs, you saw in the basement, or the finished basement, that there was an area that was an office, or appeared to be an office. Is that correct?
I don't recall the exact layout of the basement.
Do you remember that items were seized from the basement, like a Mac Pro laptop, something like what I have right here? There were 2 of them that were seized. You remember that?
Yes.
And from your investigation, you're aware that those would have been Pat Clancy's laptops, his business and personal laptop, correct?
At the time, I'm not sure who the laptops belonged to, but I know they were collected.
Okay. And how about Lindsay Clancy's, her cell phone? Was that seized, if you know?
I believe that was seized from the master bedroom.
From the master bedroom. And do you remember, was it located on the bed?
There was a phone located on the bed. I think there was another phone located in a dresser drawer. I'm not sure which phone was what, though.
All right. So both of those phones, regardless which one was what, did either one of them have blood on them?
I don't recall.
But if you guys were seizing the items in the property, such as the cell phone that had blood on it, in your experience, you probably would have remembered that, right?
Correct.
And you don't remember that?
I don't.
Okay. You did notice a lot of blood on the floor and on the walls, on the mirror and the window ledge and that area. Is that fair?
I recall blood on the floor, by the mirror, and then blood on the floor going towards that back right window.
Okay. At no time did you ever come across or discover a, what do you call it, Apple Watch, right?
No, sir.
And after you all concluded your search of the home, and how long did that take? A couple of hours?
Probably. I don't recall the exact time we concluded.
Okay. The next thing you did was to go to the Brigham and Women's Hospital, is that right?
After the search warrant?
Yeah, she had asked you a question about Brigham and Women's. I mean, did you do something else in between? I don't know.
I don't recall exactly what I did after the search warrant, but at some point I did go to the Brigham.
Okay. Can you tell us when you went to the Brigham?
I don't recall the exact date.
All right, so whatever date you went to the Brigham, you went there for what purpose?
She was transferred to that facility, and it was to maintain custody of her at that point.
So you were going to maintain custody of her?
So the sheriffs, I believed,
Right.
had custody of her, and then our unit was tasked to facilitate providing coverage over the next couple of days.
Right, and she was actually in the bed with all, again, tubes and all sorts of things coming out of her body when you saw her, right?
Yeah, she was in the hospital bed.
And she was in like an emergency room. It was a little small room with a lot of machines in it that took up a lot of space, right?
I don't think she was in the emergency room. She was in one of the floors.
One of the floor rooms, but it was an intensive care unit, right?
I believe it could have been the surgical intensive care unit.
Surgical intensive
Yeah.
care. And when you went there to facilitate custody, who were you facilitating custody for? The DA's office?
Yes, essentially.
Okay. And whatever, do you remember how many days? Was it like 2 days, a week, 2 weeks after the incident that brought you to the house in Duxbury? Do you recall how long it was before you went to the hospital to maintain custody, facilitate?
I don't recall how many days, maybe 2 or 3. I'm not sure the exact count.
All right, so she had been transferred out of South Shore Hospital. She was transferred to Brigham and Women's Hospital. You went to Brigham and Women's Hospital. I imagine you had to go through security to get in there, right? Well, your badge, right?
At some point, yeah, we were probably assisted with security to get
Right.
up there.
Well, you know that nobody could get access to Lindsay Clancy in that hospital, and I mean nobody, right?
Correct.
And this went on for day after day after day, to your knowledge, facilitating, right?
Correct.
Her parents couldn't get in to see her, correct?
I don't believe so.
She had an attorney that had difficulty, not me, but another guy that had difficulty getting in to see her. Isn't that right?
I'm not aware of that difficulty.
I had to get a court order to get a doctor in there to see her, didn't I?
Yes, it was a court order.
And when I got the court order, a doctor came in and met with Lindsay pursuant to that judge's order, and that was Paul Zeisel, correct?
I believe that's the name. I'm not sure if he was a doctor, but I believe that was the gentleman that came on the court order.
Okay, only because in your direct you said that he was not a doctor, but he was a psychiatrist. So, I mean, it's just, you knew that he had something to do with head doctor, psychiatrist, psychologist, something like that.
Correct.
Okay. Did he have to clear it with you to get into the room?
He checked in with myself and the other trooper. We were advised that he was coming and to let him in on the court order.
All right. Now, I wasn't there on that occasion, right?
No.
And when Dr. Zeisel, or whoever it was, went into the room to see her, it's your memory that he was allowed to shut the door. Is that correct?
I believe he shut the door.
Now, you were involved in this investigation pretty intensely working with the DA's office, right?
Correct.
Isn't it fair to say that one of the contentions of the district attorneys is that Paul Zeisel, my doctor, that I got a court order to get in to see her, told her to call Pat and tell him that she heard voices?
Objection.
Can I see counsel sidebar in regards to this?
Did you have further conversation with her about your previous recommendations about partial hospitalization programs?
May I review?
Yep.
Thank you. Yes, we did have further conversation about recommendations.
Okay. And did she indicate to you that she would be starting a program soon?
Yes, she indicated that she would be starting a partial hospitalization program in Norwell on December 20th, 2022.
Did she provide you any details about that program? Do you know?
No, just that she would be starting a program in Norwell.
Had you referred her to any programs in Norwell?
No.
And in this meeting with her, did you continue to talk about her need for higher level of care?
Yes.
And did you make recommendations on a different program?
Let me just look. Yes, I did make a recommendation on women and infants.
And why did you recommend women and infants, or why were you recommending this higher level of care?
I was recommending this higher level of care because of continued passive suicidal ideation, even with crisis intervention, as well as women and infants was more so for postpartum women, and the infant would be able to come to the program with her.
And so the program at Women and Infants is something that you're familiar with working through your clinic, correct?
Yes.
And you often make referrals over there?
Yes.
Do you require the patient's consent to make a referral?
Yes.
Did Lindsay Clancy consent to the referral at that time?
Yes.
And so did you work to make that referral after that visit?
Yes.
Now, you mentioned that she had continued passive suicidal ideation. In this meeting that you had with her, did you assess that? Her suicidal ideation?
In this visit particularly, did she have passive suicidal ideation?
Well, do you ask if they still have that?
Yes.
Or if they currently have thoughts of suicide?
Yes.
And in this instance, did she have thoughts of suicide or wanting to die?
Just reviewing. Hold on. So yes, she reported continued suicidal ideation at the time.
But did she ever indicate a plan?
No.
Having met with her on the 12th, did she ever articulate to you that she had made any attempts?
No.
And
Okay. Now, did you know that she had been seeking and receiving therapy? I don't know if that's therapy or counseling or that type of thing. Like there's a woman that works in your business that provides therapy, right?
Yeah, so that person would be me.
So did she come to see you for therapy?
Yes.
How many times?
4.
So is it fair to say that she was more than willing to accept help from somebody like you?
Yes.
She didn't appear to be avoiding any therapy when recommended, right? If you could, Ms. Dukes, please look at I think it was December 12th was the next time perhaps that you saw her,
Okay.
unless it's, there's another intervening period.
So there's December 12th, and then there's December 5th.
Oh, okay. So if you could pull out December 5th,
Yes.
and if I can come up and look at it.
Yeah. Yep.
All right. So on December 5th, again, you were meeting with her for therapeutic intervention, right?
Yes.
And that on this occasion, she reported she had a difficult weekend, right?
Yes.
Intrusive thoughts of wanting to die, right?
Yes.
That she contacted Aspire Crisis Support, right?
Yes.
She met with an Aspire clinician, right?
Yes.
And what happened when she met with the Aspire clinician?
She met with the clinician virtually and was told that she did not meet the criteria for inpatient treatment due to not having any suicidal ideation plan.
So if she said, in addition to the fact that she's been in counseling and therapy and seeing psychiatrists and on medications for the past 3 months or whatever the period ultimately would be, and that she wanted to kill herself, didn't want to be here, couldn't care if she died, they told her because she didn't have a plan that they couldn't help her?
Correct.
Did they, to your knowledge, make any recommendations? Did they recommended that she attend a day program?
Yes.
All right. And that person from Aspire then said he would send her patient resources, right?
Correct.
But nothing ever happened. He never sent her any. You did, but he never sent her any patient resources, right? If you know.
Not to my knowledge.
Okay. And you're aware that she was given the Edinburgh test and had a 23 out of 30, I think it was.
I was not aware.
Okay. And some women develop panic attacks referred to as hypochondriasis. You'd agree with that, right?
Agree with that in reference to.
Lindsay, she had panic attacks and complained of having panic attacks.
Yes.
Okay. And then you can get into the various diagnoses of which, on a postpartum person in that time frame, obsessive compulsive disorder, OCD, right?
Correct.
Or bipolar 1 or bipolar 2, right?
Are you using them interchangeably or could develop?
Trust me, let's say bipolar 1,
Yeah.
okay? So that would be one mental disease, correct?
Correct.
And it's pretty serious stuff, right?
Yes.
And if a person is diagnosed as bipolar, one of the things that you shouldn't, if you know, is prescribe SSRIs such as Prozac or Zoloft, right? If you know.
I'm not sure of that.
Okay. Would you agree that with various cases dealing with postpartum depression, all of the symptoms that we talked about, they utilize the Edinburgh Postnatal Depression Scale, which is a 10-item questionnaire that can identify women that have postpartum depression and the severity that they have. And on the scale, a score of 12 or greater it raises concern and indicates a need for more thorough evaluation, right?
Correct.
Do you know whether she was thoroughly evaluated by anybody other than Tufts and Gelada?
I'm only aware of Tufts and Gelada.
Okay. I mean, you were trying to do the best you could with what you had to work with, right?
Correct.
Okay. Now we get to postpartum psychosis. That's the third category, right? Postpartum psychosis, you'd agree, is the most severe form of postpartum psychiatric illness. Is that right?
Correct.
Would you agree that it occurs in averages about 2 out of 1,000 women, right?
Correct.
And its presentation can be very dramatic with onset of symptoms, and that can be within a year, according to the CDC, Center for Disease Control,
Yes.
right? Okay. And when it hits you, it just hits you, bang, quick, right?
Correct.
And when you think about 2 out of 1,000 people, seems like a daunting number, but if I tell you that Fenway Park, when they're full, when they're playing the Yankees, they have 37,700 people. If you take the 37,000 people and you multiply it by 2, that would mean as you're sitting there behind first base, 74 women possibly have postpartum psychosis, right?
Not sure of that number, but
Well, if you agree that it's 2 out of 1,000 according to the studies and the statistics, and if Fenway Park has 37,000 seats, times 2 would be 74.
okay.
That's a pretty large number of people, right? 74 people out of that crowd? Okay. It's not that horribly unusual. I mean, it's something that perhaps you've dealt with in your practice, right?
Yes.
And when you're dealing with people with postpartum psychosis, do you agree that generally they present with an episode of bipolar illness? If you know.
No.
No, they don't, or no, you don't know?
No, I don't know.
Okay. Bottom line is, from your dealing with Lindsay, she appeared to be sincere, right?
Correct.
She appeared to be looking for help, right?
Correct.
She appeared to be hurting, right?
Yes.
Turning in every direction she could for help, right?
Correct. No.
And as of your last meeting with her on December 19th, ultimately, what were your impressions of how she was doing?
My impression was that her symptoms were improving because of the social aspects, spending time with family and friends and able to exercise when before it was difficult for her to engage or pay attention.
And your observations of her while you were interacting with her, were they more positive than on previous occasions?
Yes, she was able to smile and laugh.
Okay, thank you.
What was she laughing about? When was it she was laughing with you?
I believe that was the last visit, the 19th.
So on the 19th, it was on television, or was it in person?
It was a virtual visit, a video
Virtual visit.
Yes.
And on the 19th, on the virtual visit, what was the purpose of that visit?
The purpose of that visit was to see if she was able to connect with care.
Okay. So you would have, I guess, in your notes or a reference to the fact that on the 19th of December that she was laughing.
Not that she was laughing, but that she was able to laugh.
Able to laugh.
Yeah.
Okay, because I'm looking here on December 19th, telemedicine, Latiesha, I apologize, Dukes, perinatal behavior health program, and you talk in that form about the date of the service, December 19th, psychotherapy, PCP, Margaret, that would be the primary care, Margaret Anastasia, perinatal behavioral health program, you talk with the quote, if this is telehealth visit, please dot the phrase video visit, whatever. Therapeutic intervention, she's 32 years old, married, female, presents for postpartum anxiety. Symptom management, patient continues to have low mood and numbness. Numbness. Was she laughing when she had numbness?
What date are you looking at?
December 19th, the last day you saw her, or the last time you had any contact with her.
She didn't appear to have that, no.
She didn't appear to have what, laughing or numbness?
Numbness.
Well, it says right in the notes, does it not, that patient continues to have low mood and numbness.
Yes.
Okay. I don't want you to say yes unless I show it to you. So, the patient continues to have low mood and numbness, right?
Correct.
Patient has not had suicidal ideation and did not need crisis intervention over the weekend. In other words, she didn't kill herself, right?
Correct.
To help with the mood, patient has been spending time with her husband, children, and exercising, right?
Yes.
And exercise is one of the things that you would generally, your people would generally recommend that the mother do, right?
Correct.
That's a good thing to try to do, is to exercise, right?
Correct.
So the fact that the government has records that show that she would take her kids or her husband would take her kids, that they would go to a local gym and exercise or swim, that's consistent with what she was advised, right?
Correct.
It doesn't mean that she's just out there having a good time exercising, right?
Objection.
No, overall.
She was told that that's a good thing to do, right?
She was told that that was a good thing to do, but the fact that she's able to follow through and do it shows improvement.
Oh, okay. So when did she go to the gym?
She didn't give me exact dates. These are things that
Did
she
you ever
told me
ask her?
she did.
Did you ever ask her? If you're telling me that, this is showing improvement, is it in the records? Does it indicate that you asked her if she was exercising, and if so, where and when?
So we don't write down everything that we talk about in the meeting. It's particularly a summary of that visit.
Okay. And all I did was ask you about the patient was spending time with her husband, children, and exercising, and then you said that that's an indication that she's improving.
Correct.
Okay. And then I asked you if she's going to a gym. That's not a bad thing, is it?
No, it's not.
Okay. And then it says that she received a call, and counsel asked you about this. She received a call from women and infants, but missed the call. Do you remember that? Remember the DA asking you that question? You said that she missed the call.
Yes.
She didn't continue to read that the reason she missed the call is that she was at another medical appointment, right?
Correct.
And she called you back, right?
Yeah.
Okay. Clinician, you, provided contact information for women and infants. Patient reported that she would contact them today, being December 19th, but in fact, she did, and you did with, back it up. She did with your help, and she then went the following day on the 20th, right?
Correct.
Okay. And finally, fair to say that nowhere in here does it say that she was laughing?
You would have to go to the assessment, the risk assessment.
Okay, let's do that. You got it? Let me see, please. Okay. Now, what's a mental status exam?
So a mental status exam is to assess how the person is appearing that day, their mood and their interaction with you in that visit and how you perceive them.
Okay. So, with the help from the DA, we have December 19th, the telemedicine form, clinical notes, right?
Yes.
The laughing wouldn't be in that area, would it?
No, it would be more so in this area.
Yeah, okay.
Yes.
Mental status exam, right?
Mm-hmm.
Appearance, hygiene, WNL.
Within normal limits.
Okay. Clothing normal, eye contact normal, build normal, posture normal, body movement normal, right?
Yes.
Behavior is cooperative, right?
Yes.
And speech is within normal limits, is that correct?
Correct.
Emotional state, affect. Patient reports feeling numb and having low mood for most of the day, right?
Yes.
Facial expression, other. Facial expression, calm, was able to laugh and smile, right?
Yes.
Would that be in response to you saying something funny, or why was she laughing?
That would be in response to me saying something funny.
So you guys were kind of bonding a little bit.
Yes.
All right. But she basically still continued to report that she was numb, having low mood, and basically the symptomology that she had already reported, right?
Correct.
Okay. Thank you, ma'am. I appreciate it.
All right, Como?
Nothing further, thank you.
All right, thank you. Thank you. You may step down. Thank you. Good afternoon.
Good afternoon.
All right, Ms. Sprague?
Thank you, Your Honor. Good afternoon. Can you please state and spell your name for the record?
Yes, my name is Renee Stonebridge, ReneeStonebridge.
Where do you work?
I work at the Commonwealth of Massachusetts at the Boston office.
And what department do you work for?
I work for the Chief Medical Examiner's office.
And how long have you worked there?
I have worked there since July of 2017.
And can you describe your educational background?
Yes, I did 4 years of college at SUNY at Stony Brook in New York. I was a double major in German languages and literature and biology. And then I did 4 years at the American University of Antigua, where I got my medical degree. I also graduated with honors, magna cum laude. After that, I did a 4-year combined anatomic and clinical pathology residency program at NYU Winthrop Hospital in Long Island, New York. I also served as chief resident during my final year there, so 2016 to 2017. After that, I did a 1-year forensic pathology fellowship at the Boston Office of the Chief Medical Examiner. And then after that, I did a 2-year neuropathology fellowship program through Brown University at Rhode Island Hospital. And I am board certified in forensic pathology, anatomic pathology, clinical pathology, and neuropathology.
What is neuropathology?
Neuropathology is the study of the brain, the dura, the eyes, and spinal cord, and muscle.
What is your role at the Office of the Chief Medical Examiner here in Massachusetts?
My role there is the Director of Cardiac and Neuropathology. I'm also a medical examiner, but my primary focus is brains and hearts.
And so will there be an occasion where a medical examiner is doing an audit? Why is it that these types of hemorrhages occur in the eye?
What happens when there's some sort of asphyxial element to a person? It could be from many different things, but what happens is the blood in the head, if there's, say, some type of compression of the neck or something else that causes asphyxia, there's many things, but if there's some sort of compression, the blood basically gets kind of stuck in the head area, and because the blood can't flow back down through the body, what happens is there's little tiny blood vessels. They're in the eyes, they're in the skin, in the mouth, all over the head region. They basically get blocked up with this blood because it can't move. And these little blood vessels will burst, which leads to these little hemorrhages.
And in terms of Dawson Clancy, what did you examine with Dawson Clancy?
For Dawson Clancy, I examined the eyes as well.
And what were your findings?
The findings were that there was also some acute hemorrhages in these muscle and adipose tissue surrounding the eyes. And then the right eye had some small hemorrhages in the posterior retina and the optic nerve sheath. So the back of the eye, there's the retina within the eye, and the retina connects with the optic nerve at the back portion of the eye. And in this case, there was a little bit of hemorrhage at that connection point where the retina connects to the optic nerve.
And what is hemorrhage?
Hemorrhage itself is just blood that is no longer contained in a blood vessel.
So it's burst from that vessel?
Correct.
And then in terms of Callan Clancy, what did you examine with Callan Clancy?
For Callan Clancy, I examined the brain, the dura, the spinal cord, and the eyes.
And what were your findings?
The findings were that there was hypoxic ischemic changes. Essentially, that means that there has been some sort of incident which has caused the brain to have a certain period of time in which blood and oxygen flow were not appropriate. So in this case, there was a time frame in which there was no blood going to the brain, there wasn't enough oxygen going to the brain, and the brain will show certain findings in these sort of circumstances. One of the things I note is that there's edema. Edema is when the brain starts to swell. Edema is also a very general finding. It can happen in many instances, but the edema basically means that the brain starts to swell, so you don't have the nice kind of bumpy pattern on the brain. It starts to swell up and it gets a little more flattened because the brain is encased in the skull, so now it's pressing against the skull because it's swelling up and getting bigger. One of the other things I noted with that was that there was compression of the ventricles. So the ventricles are almost like a tunnel system inside the brain that allow for the cerebral spinal fluid to flow through the brain and go into the spinal cord. And when the brain starts to swell up, it not only swells up outwards, but swells inwards on itself as well. So these ventricles that are located in the inside portion of the brain are starting to get kind of squashed because the brain is swelling. Another thing I noted was that the brain was diffusely friable, meaning that it's very soft. So one of the things I do on all my brain cases is they go into formalin. The formalin allows them to fix, which basically firms up the tissue. And it makes the tissue more easy to manipulate. A fresh brain coming out of a skull is very soft. It's very easy to damage it. It's very easy to put your fingers through it if you're not careful. So one of the things that gets done is these brains will go into formalin. I typically will let them fix for about 2 weeks or so. And sometimes, regardless of the fixation time at the formalin, sometimes the brain still will not firm up the way it should, because if I'm receiving a brain and it's already has hypoxic ischemic changes, the formalin is only going to penetrate the tissue so much because the tissue is essentially already dead.
Can I just stop you for a second? What is hypoxic ischemic changes?
Hypoxic ischemic changes is when you are getting lack of blood and oxygen flow. So hypoxic is the oxygen portion and ischemic is the blood portion.
So what you saw with Callan's brain was consistent with a lack of blood and oxygen?
Correct, yes.
Which then led to brain death?
Correct, yes.
How long, based on your training and experience, does it take for a brain to start dying after the loss of blood flow and oxygen?
It varies based on different sources. Most sources say it's between about 6 to 8 minutes. If there is no oxygen flow, then the brain will essentially start dying. It depends on, if there's resuscitation that occurs afterwards, but it's generally in the frame of 6 to 8 minutes or so.
And once brain tissue dies, it can't be brought back, correct?
Correct, yes.
I have nothing further. Thank you.
You're welcome.
Does it take for loss of consciousness to happen?
I cannot put a specific time on it for the interval. There's multiple variables to consider in a case-by-case basis. The type of ligature used, the force of the ligature used against the neck, as well as the intensity and duration of the altercation. However, in situations where there's complete oxygen deprivation, loss of consciousness can occur as early as 10 to 30 seconds, with brain damage beginning at the 1 minute mark and irreversible brain damage and subsequent death occurring around as early as 5 minutes, again with the caveat that there are variables that might accelerate or decelerate that time frame.
Is there a type of constant pressure that's required to cause that loss of consciousness?
Ultimately, once the brain has a critically low level of oxygen, a loss of consciousness will occur. It takes an average of 4 pounds to compress the veins of the neck and an average of around 10 pounds to compress the arteries of the neck.
And so if someone's squeezing something or pulling something around the neck at that 4 pounds or 10 pounds of pressure in a consistent basis without any resistance, does unconsciousness happen faster?
It could occur faster, yes.
What if someone's resisting or struggling or pulling away? Could that take longer?
When the body is in a state of stress, you have a stress response that demands an actual increase in oxygen utilization by our body. So in the presence of an increased demand with a decreased amount being delivered to the brain, it can accelerate the timeline to loss of consciousness.
What do you mean by accelerate the time to loss of consciousness?
It's obvious what she means.
No, overall, you can ask.
It would just make it occur faster.
And so if that pressure isn't constant, say someone struggles and is able to get free a little bit, and then you have to tighten it again, does that make it take longer?
Sustained.
You said anywhere from 5 to 30 seconds. What are the factors? I'm sorry, you said 10 to 30 seconds. Is that correct?
Yes, for loss of consciousness.
What are the factors that are at play for whether it's 10 seconds or 30 seconds?
Again, there's multiple variables. The force of the ligature against the neck, the actual ligature itself, and the intensity and duration of the altercation.
And once someone loses consciousness, do they immediately die?
No. So if there's no intervention, the brain continues to have a lack of oxygen. And so until the brain cells start to die, it's irreversible injury to the brain. The person is alive until the body can no longer sustain the lack of oxygen.
If someone is strangled to the point of unconsciousness and the strangulation stops, can they wake up?
Without intervention is very unlikely.
So do you recall testifying previously that when asked if a person were to use a ligature around someone's neck to the point where they pass out?
But, counsel, we had that answer, right?
It's an inconsistent statement.
This is your witness.
I know, and I can impeach with an inconsistent statement.
I see it's sidebar.
Past the 30 seconds to cause death.
No. Once the brain is subject to oxygen deprivation and brain cells start to die, it's irreversible. And so it will continue to progress towards death if there's no intervention.
What do you mean by intervention?
Resuscitative efforts, if somebody tried to give CPR, if they were hooked up to oxygen machines.
Do you recall testifying previously that it would be your opinion that pressure would need to be continually applied even after losing consciousness to cause death?
Sustained. Hold on. Sustained. Next question.
So your testimony is that you can strangle someone for 30 seconds, let go, and then they die?
I said that in this presence of complete oxygen deprivation, there is a general time frame. And so 30 seconds, I cannot give a specific number to that. Once strangulation occurs, again, the brain starts to be subjected to a lack of oxygen. So whether the ligature is present or whether the ligature is not present, the oxygen deprivation and irreversible brain damage is already occurring.
And there's no coming back from that?
Not without intervention. It's very unlikely. Again, the brain cannot heal those cells.
Did you form an opinion to a reasonable degree of professional certainty, to medical certainty, as to the cause of death of Cora?
Yes.
And what was that?
Asphyxia.
And was that by manual strangulation?
By strangulation.
Mechanical strangulation, I mean. Yes.